So today I'm going to talk about transforming CAUTI prevention in implant patients through infection-controlled Foley catheter. And a lot of my colleagues will agree that we all need to do that. This is just a disclaimer. So prevention, of course, we know is better than cure. There's no need to emphasize on that. This is where I did my training from US and Canada. So 7 out of 100 hospitalized patients get healthcare associated infection, and out of which 1 in 3 belong to the intensive care. So 40 to 60%, of course, are caused by the medical devices, be it like intraop cath, procedures for knee replacement, surgical machineries, and all that. Implication of medical device-related infection, of course, what happens here, we have an interrupted treatment, so the chronic disease can further be trailed, and there can be, a death as well. The other risk of complication, of course, includes your sepsis, DIC. There is increased use of antibiotic, which drives the antimicrobial resistance. There can be episodes of rehospitalization, extended hospitalization, and of course, to further worsen, increase in the healthcare cost. So to mitigate these negative consequences, it is of course crucial to prioritize the infection prevention measures to reduce the risk of device-related infection and ensure uninterrupted and effective patient care. So UTI or urinary tract infection is one of the most common hospital-acquired infection, often around 90% caused by the indwelling urinary catheters. 1 to 5% of all CAUTI leads to urosepsis, where you have a positive urine culture as well as fever. AMR or antimicrobial resistance is one of the most acute healthcare risks of our time that can take us back to a time even before the antibiotics. What I mean here is even before we had the antibiotics, having antimicrobial resistance is pretty much same. So even if you have antibiotic, that's not going to work when you have enough resistance. So at least 70% of all hospital-acquired causing bacteria are resistant to at least one antibiotic that we use in our routine practice. AMR, so this is a data by Global Research on Antimicrobial Resistance, which was a project. So if you look on the left side, 2016 witnessed around 700,000 deaths due to antimicrobial resistance. In 2019, that went up to 1.27 million, and the prediction is that between 2025 and 2050, there can be approximately 39 million deaths, which is just like 35 times of what we see now. So that's a huge number and a huge risk, a huge loss of life. In the HI setting, which is hospital-acquired infection in recipients, where we deal with solid organ transplants, I and Dr. Hunez are into liver transplant, and there are a lot of doctors who deal with the renal transplant. They have high incidence of acquired infection than in the population without transplant. In one of the data which was a study done between 2013 and 18, where the subjects were around 4,300, and this study was done in Spain and Cuba collectively. So there they witnessed that renal transplant recipients showed 26% incidence of acquired infection, where the mortality was around 3.8%. In the liver transplant setting, recipients showed 41% incidence of hospital-acquired infection, where the mortality was really, really high, which was 37%, although we don't see the same numbers in our setting here. The population without transplant in the ICU, of course, had 17% incidence of acquired infections and mortality of around 21%. Now, we know that UTI is one of the most common main complications in kidney transplant recipients, with a significant impact on the graft function and survival. So it is estimated that around 74% of kidney transplant patients experience at least one episode of positive urinary tract infection in the first year of life post-transplant, with an increased risk of a graft loss, or there can be increased risk of mortality as well. Now, multi-drug resistant infection is common even after liver transplant, and infections are one of the leading causes of morbidity and mortality after liver transplant. And this can be because of immune dysfunction, they can be due to surgical intervention and increase in hospital days. Infection of interest, of course, are the primary ones. I'll start with respiratory. I think the higher numbers are the LRTI, followed by the UTI, then there can be hepatic or intra-abdominal abscess, since there's a surgical site which can be infected, and there can be abscess around that too. Now, bacterial infections in the first 90 days after liver transplant occurred among 41.3%, and then 15.3% had multiple episodes of infection, not just one. The most common infection, as I said, were respiratory, mostly LRTI, followed by UTI, which was around 18.5%. And of this, the culture positive infection rate was around 75%. So these are also culture positive, and we can document the same. So this is one of the data, very old data between 1970 and 75, where they did an intervention, which one was without infection control and the one was with infection control. So we see, even if it is LRTI or sepsis, systemic sepsis infection, UTI, blood infection, and the total number of infection rates had actually gone down with just simple measures of infection control: washing hand, wearing gloves, and doing the right thing. So are we future ready for DHAI and AMR? So there are challenges, and then of course there are opportunities, and there's no single silver bullet here. So preventing hospital-acquired infection is as equal as evading future antimicrobial resistance. So here HAIs are often caused by resistant bacteria. The way to prevent is the key. So prevent the biofilm formation, and then the infection will definitely not happen. Biofilms do help perpetuate and AMR, and on the right side, the expansion into research of having into non-biological biomolecule Bactiguard, which is noble metal alloy coating, approaches to keep the bacteria away from not letting it attach to the surface, and this is how the organism will not thrive. The discovery and development of antibiotics have been declining, so we have limited antibiotics these days. In the past few decades, there have been very few antibiotics which have come up. Now, developing advanced diagnostic methods and susceptibility testing is the way forward. AMR likely compromises the safety and efficacy of the surgical procedures, which includes the implant, transplant, and other surgical methods. Discovering effective vaccines, bacteriophages, or immunotherapies are the way forward here. So prevention is, of course, a holistic approach. The way we do it is, of course, one is indication. So only catheterization as and when required should be done. Of course, handling with care, so ensuring that all aseptic measures have been followed and preventing any kind of trauma. And the material, the choice of catheter, of course, is very important. So here I'm talking about the Bactiguard's noble metal coating, which prevents the infection. Now, what is a biofilm formation? It's a hidden thread on the medical device. It can be a catheter, it can be a central line, it can be anything. So you can see this on your chart here, that after a few seconds, the microorganism, they start forming. They start aligning on the uncoated surface of any indwelling catheter. And after 2 days, you can see the rise in their numbers. So biofilm protects the microbes from any immune response and, of course, the antibiotics. Early prevention of bacterial adhesion is the crucial way to avoid colonization and the biofilm formation. Now, revolutionizing the CAUTI management with infection control urinary catheters, and what is it about is in my next slide. So basically, there's a galvanic effect. Now, this noble metal alloy is made of gold, silver, and palladium. It forms a kind of microcurrent which does not interfere with the host, but definitely it interferes with the microorganism by not letting it settle down on the surface of the indwelling catheter, even a Foley. So there is no formation of biofilm. And the bacteria, of course, the bacteria will begin to adhere after a few hours. They're still there, but they are still not on the surface. And even after a few days, they're still there on one side, but they do not colonize the entire indwelling catheter. Now, few bacteria adhere to Bactiguard-coated surface. So this is a comparative chart. On the left side is uncoated surface, and on the right side is the Bactiguard-coated surface. So you see a lot of colonization here on the coated surface, on the uncoated surface. And with the Bactiguard, of course, they cannot colonize. They do not form the biofilms, and it is much, much safer. So this is in vitro data, where we were able to, with the Bactiguard-coated Foley's catheter, not just fecalis, but other commensals like E. coli, Pseudomonas, and even staph were able to be kept away from it. So well proven and efficient, and it's safe. So more than 100,000 patients included in one of these trials, which has not still been published, which included 40 clinical studies. Meta-analysis shows 45% reduction in the overall infection. shows, most recent RCT studies, of course, show 70% reduction and approved for class 3 medical devices. So significant reduction of CAUTI. This is one of the studies done by Carl Larson and colleagues in India. So they had 6 sites across India which had the government hospital setups and the private. The total number of subjects were around 1,000, of which 750 had BIP, which is your Bactiguard infection protocol. And the other ones had standard catheter where they just had the coated substance on it. Patients basically went urologically surgery, they had a general surgery, or they were just in the ICU. The mean time of catheterization here was around 11 days. It was, of course, randomized, multi-center, and prospective. So if you see on the right, the difference is huge. It's very evident that standard catheter had, a high risk of infection where compared to your BIP Foleys, which had the enema coating, and even after 10 days or 1 week, if you had to keep the catheter inside, the number of urosepsis episodes were very low. So another study by Leder and colleagues, this was basically published in Journal of Wound Ostomy Care. They had around 853 subjects, and both the subjects were equal, 453 in the control group and 400 in the Bactiguard group. Basically, these were hospitalized patients between the age of 18 and 89, and some of them were on ventilators. The mean time was 8 days, and the site was 7 acute care hospitals across USA. Endpoint was symptomatic CAUTI based on the CDC definition, and the others were the antibiotic use. So, of course, Bactiguard coated catheters had lower rates of infection, urosepsis, and had a better outcome compared to the ones who were on standard catheter. So just the last slide. So device-associated infection, there's a comparative data between uncoated, antimicrobial coated, and Bactiguard. So of course, uncoated will have very high risk of DAI and high risk of biofilm formation, leading to multiple uses of antibiotics, leading to resistance to antibiotic. Good bacteria will be outcompeted by the bad ones, of course, weakening the immune system. Compared to that, the antimicrobial coated, of course, is much better than the uncoated ones. They have low to medium risk. Of course, you'll have to use the antibiotic in case of urosepsis here. Since it is antibiotic coated, it's going to kill the normal commensals, the good bacteria too. Antibiotics can, of course, impact the human cell function. And since it's based on the releasing of the antibiotics, the effect decreases over a period of time. Whereas in Bactiguard enema-coated surface, you have low risk of infections, biofilm formation, no antibiotic use, and no risk of antimicrobial resistance here. Immune system is still intact, does not kill the good bacteria, so there won't be commensal overgrowth here. Non-releasing, so it can be used for a longer duration. You can use it for weeks, at least 4 weeks, and then there's no risk of resistance as we see in the coating. So that was about Bactiguard and the coated enema-coated Foley's catheter. I'm open for questions if there are any.